Hello, my name is Michael Tam and I thank you for watching this poster presentation titled Detection of At-Risk Drinking, Beliefs and Attitudes of Australian GPs. I'm a GP and lecturer in the School of Public Health and Community Medicine at the University of New South Wales. This research forms part of my Masters in Mental Health at the New South Wales Institute of Psychiatry. My co-researchers are Professor Nick Swar, Professor of General Practice in the school, and Dr. Rosalind Markham, Research Postgraduate Coordinator at the Institute. This research was a joint project between the school and the Institute. I also acknowledge New South Wales Health, who provides a scholarship for the Master in Mental Health. Harm from alcohol consumption is a significant public health issue. It is common in Australia. Around 30% of patients who present to GPs drink at at-risk levels. Primary care has been identified as the priority health setting, as most at-risk drinkers will consult with a GP over a 12-month period. However, the majority of at-risk drinkers are not identified by GPs. Screening questionnaires such as the Audit C appear to be effective at detecting at-risk drinking. Preventive health recommendations typically advocate for GPs to routinely use screening questionnaires. However, uptake of these tools is very low. We wondered, why is this the case? The aim of this study was to describe GP perceptions on the detection of and screening for at-risk drinking, and also specifically the role of the Audit C, the screening questionnaire that is recommended in Australia. By analysing these beliefs, we sought to understand the low uptake of screening questionnaires as well as the overall low detection of at-risk drinking. We used qualitative methods in this study. Data was collected using focus group interviews of a sample of Sydney GPs in teaching practices. Each focus group began with the participants giving an estimate of the prevalence of at-risk drinking. Further questions were used as triggers if the points did not arise naturally in discussion. A printed copy of the Audit C was handed out to the participants towards the end of each focus group, and the GPs were asked on what they thought of the tool. Transcribed digital recordings were imported into In Vivo 9, and the data was analysed using Straussian grounded theory methodology. A total of 4 focus groups were run, with 19 participants. As thematic saturation occurred by this point, no further groups were sought. The GPs in our study were average overall in terms of patient load and appointment length. There was a mix of male and female GPs. There were 7 GP supervisors, who on average had 22 years of GP experience each. There were 4 GP registrars, 7 other GPs, and 1 junior hospital doctor working in a general practice rotation. Our analysis identified 4 major areas. The sequence of these themes and topics reflects the conversational flow of the group interviews. The GPs started with dialogue on their beliefs and attitudes on detecting at-risk drinking. Almost all the GPs noted that detection of at-risk drinking is important. However, it was perceived that patient histories are unreliable, and this was identified as a major barrier. Many GPs were reluctant to label a patient with at-risk drinking. They were concerned of being seen as moralising. Discussions tended to be around their lack of effectiveness in detection and in changing patient behaviour. The GPs then reflected and debated the wider role of societal attitudes in sociocultural contexts. Important themes that emerged were that many patterns of at-risk drinking are socially normal, and that problem drinking labels are shameful and stereotyped. This had a number of impacts on patient beliefs and behaviours. The GPs also focused on the issues at the level of the consultation. The major theme was that assessing alcohol was a potential threat to the patient-doctor relationship, something of key importance in the GP setting. This threat was magnified and lessened by a number of factors. Lastly, the GPs discussed their beliefs about screening questionnaires and the Audit C. Importantly, routine screening questionnaires were not perceived as pragmatic in the GP consultation and were rarely used. When they were used, it was often to help build rapport with a patient already identified with alcohol use disorder, rather than case finding. The GPs were highly sceptical of the scoring of the Audit C, and it was not perceived as useful. In our analysis, it appeared that sociocultural factors had a substantial influence on the detection of at-risk drinking. There appeared to be 3 linked major barriers to GPs detecting. The first major barrier is community stigma and the stereotypes of problem drinking. Firstly, this has direct effects on detection of at-risk drinking. GPs didn't want to be seen as moralising to patients. The second major barrier, GP perceptions that patient alcohol use histories are unreliable, can be seen as a consequence of stigma. Patients hold on to the identity of the normal drinker and reject the stereotypes that lead to social exclusion. However, the community framing of alcohol use along a dimension of normality leads to patterns of drinking that are judged as normal but objectively harmful to health. This social construction appears to be the source of GP perceptions of patient defensiveness, denial, and secretiveness when asked about their drinking. The perceived threat to the patient-doctor relationship from alcohol use assessment is the third major barrier. Asking about alcohol can be uncomfortable for both parties, and detailed questioning may be seen as an attack on the patient's integrity. Specifically, when assessment wasn't seen to be within the expected scope of a medical consultation, it was perceived as illegitimate. What is perceived as being within expectations is again influenced by sociocultural factors. Importantly, the Audit C and perhaps most alcohol screening questionnaires in themselves don't address these three barriers to detection of at-risk drinking in the GP consultation. I've included on the poster a particularly representative statement by one of the GP participants that captures the influence of societal factors. She said, "It's socially unacceptable to say you're a heavy drinker, but it's actually socially acceptable to be a heavy drinker. That's the problem." Our conclusion is that in the current context, it is unlikely that approaches that focus on routine GP use of alcohol screening questionnaires will be successful at improving detection of at-risk drinking. Thank you for watching our poster presentation. I'm happy to receive any comments, feedback and correspondence on our research. Special thanks must go to all the GPs who agreed to participate in the focus groups and for the interviews to be recorded, analysed and archived. Thank you again.